Okay, first off, when I posted this assignment, the first 5 days, virtually nobody sent me an email. So I thought there was no problem, until yesterday there's a few emails. And then when I opened the assignment, there are a few people who finished the assignment, but the grade was kind of low. So I'm hoping in the future. I discussed with the earlier class. They said it was because you have a challenging exam, everybody is stressed out. If anybody, like the president can send me a message and say, we're all stressed out, I can move this assignment, like start with a little bit day later and postpone the deadline. But if you don't tell me, at least nobody even tell me that, okay? And as last time when I said, I'm here to provide help, I will let you guys know, even though the exam is going to be online, so I will not be as last year to directly tell you the answer, but I can have imply and explain the questions, So if you want to optimize your grade, email me questions, okay? So, how am I going to, I have to say my understanding, why some people just, finish up the assignment, regardless of the suboptimal grades that they have. I think some of you may think she's nice, she's going to give us A anyway, let me finish this shit, okay? That's what I thought, okay? So, do you think that I could tell you, I guarantee everybody get an Ace? If a professor says that, the professor is definitely not a good one. Okay? Even though I'm wholehearted to help you as much as I can, I would love everybody to get an A, but I cannot promise that. I don't think anybody should do that. Okay? So please do not say, she's going to give us an A anyway. Let me finish this. If that's the case, then there's nobody else can help you out. Okay? In the future, let me know the challenges, ask me questions. Okay? Ask me questions. So this time, I'm gonna extend the deadline to next Wednesday. Okay? I will briefly go over the answers, but the assignment 2, I give you another week, but have questions, ask me at least a day before it's due. I normally will collect all the questions and send out, the answers or the explanations. What about if I want to finish this earlier and I got like a 12 out of 20 and 15 out of 20 without asking for help, just wanted to finish up this? Well, unless if you can prove that it's all logged into the system and completed this assignment for you. Okay, if you can prove that, I can reopen this assignment. Okay, but otherwise, given the circumstances and the fact I'm more than willing to help, please don't do that. Okay? All right? All right. So the first question, the answer is all of the above. Good reason. Is that clear? Clear. Okay. I will go through them, quickly. Questions, just ask me. Okay. For cohort study to be able to provide a high level of evidence than case control studies, the answer is 1, 2. 3, fine. Cases for case control studies, that's not a reason. And 4, more likely to suffer from sample size. Actually, case control study are, more lenient in terms of the requirements in sample size, because it starts with the cases. So even if it's a rare disease, you can collect them in a clinic, but for cohort, you need to follow them over time. We talked about in our last semester. The case control study doesn't have a naturally distributed disease sample. Okay. Number 3, what are the key elements in definitions of comparative effectiveness? Number 3. Okay, the answer is none. It's None. Okay, doesn't have to study the undeserved populations, any populations, okay? Because what is the essential goal of the comparative effectiveness is to improve clinical practice, okay? In all patients, doesn't have to be undeserved. Number two, doesn't have to test any innovative health interventions. Can test the, combination regimens, which one is better, and doesn't have to use sophisticated statistical methods. Do you think in reality, given the same validity of the study design, do you think people prefer the statistical methods to be more straightforward or to be more complicated? Straightforward, of course, that's easier for anybody to interpret and to apply. And also, the more complicated the statistical methods, the more inherent risk can be subjected to bias. Okay. 4, medical practice and occurred in recent years, not true at all. Any historical cohort? Okay. So the answer is none of the above. Number 4. The characteristics factor that differentiates randomized clinical trial from observational cohort study. The answer is, B. Involves clinical randomization, but observational cohort study don't. We have discussed this, right? In the lecture, right? Number 5. Which is not a reason why risk assessment in personalized medicine is less cost effective. Anybody agree with me that the wording is kind of annoying? Yes. Yeah, okay. So it's not my intention. Okay. If this happens again, just let me know. But this is still a doable question. Okay. So what I'm gonna do is to find out the reasons, okay, that makes the assessment screening in personalized medicine less cost effective. Okay, so what does less cost effective mean? It means it has a high cost in relation to the effectiveness, right? Okay, so now, what are the examples? Okay, test can be very expensive. That's a reason, right?
Yes.
Number 2, effective treatment can be lacking even if there is, because it's going to affect the effectiveness. That's another, okay. The prevalence of a disease, can be low. The higher the prevalence, that means with the same test, with the same cost, you can find more cases. So that's more effective, right? So the answer is C. Answer is C. Okay, the answer is C. Okay. Number 6. Which of the following is not true about comparative effectiveness research? Okay, I'm going to need to make it more straightforward. Number 6. The answer is C. Okay, tend to conduct the studies in ideal settings with optimal patient compliance. Comparative effectiveness research, the goal is to improve clinical practice. Why does it have to be, ideal compliance? That doesn't reflect the real world. Okay, so the answer is C. Number 7. Okay, CER studies contribute to the following areas except for, and which one is not? The answer is E. Guideline, insurance coverage, clinical design making for individual patients, clinical decision making for patient groups. The answer is E. The answer is E. Is it clear? Clear. Okay. RCT and observational studies mainly differ in the following areas. Okay. Patient groups, yes or no? Yes. Existing of the interventions, yes or no? Yes. Studies, sponsorship, no. Okay, RCT and cohort studies can be sponsored by pharmaceutical industry, government, organizations. The funding doesn't really systematically differ, and the existence of randomization. Okay, so the answer is 1, 2, 4. 1, 2, 4. Clear? Clear? Adam, clear?
Yeah.
Yes. Okay, I'm ready. Okay, 1, 2, 4. Number 9. The benefits of genetic testing in personalized medicine and the extent to which payers will cover the cost of the test and subsequent depends upon whether the genetic testing can help preventing the disease and to what extent, cost saving with preventing the disease, cost of developing and administrating the test, financial benefits are thought to the organization where the innovative genetic testing was developed. One, two, three. 1, 2, 3. Is that clear? Personalized medicine used in drug development is unlikely to be covered by health insurance plans because B. Any questions? Since the goal of personalized medicine is to produce a treatment tailored to each individual, the CER yields global assessment and it's not feasible to analyze the benefits of personalized medicine with CER methods. Fourth, discussed this dimension. 12. Which of the following reasons, question can be addressed by conducting a randomized clinical trial? I thought the number 1 is not because it's not ethical. Number 2 is not because it's not ethical. You're not going to be able to confine the patients into inactivity. That's not ethical. C, novel drug and end up improving lung functions among COPD patients than existing treatment group. That's true. 4, can provide education combined with simultaneous patient education lead to better blood sugar control. 3, 4. Any questions? 3, 4. Okay.
Why is number 2 not ethical?
Daily moderate to vigorous physical activity reduce the risk of the ovarian cancer. In a randomized control clinical trial, we want to make sure patients are compliant. So for the control group, would be the women who do not do physical activity. Is it ethical to make sure that they're compliant to the regimen, they're not doing any physical activity?
Oh, it's because they were controlling
Compared to simple randomization, concealed allegation, all of the above. We talked extensively about this issue in the lectures. In RCTs, the inclusion criteria are broadened. It can be lead to AB. Clear? I'm just going to go through this pretty fast. If you have any questions, let me know. Clinical trial sample size is calculated based on A. And it may indicate areas for that's the exact sentence in the slide. True. Intention to treat is likely to lead to similar to real world, while protocol analysis usually lead to results that are more pessimistic compared to real world. True or false? True or false? False. So what is the true answer?
is more likely to lead to better results. How easy is it?
Exactly. Okay, so it shows false. Which of the following are recruitment and retention techniques used in clinical trials? Okay. Communication with participants before and throughout the trial. Provide benefits of participation for subjects. Easy access to study personnel. All of the above. All of the above. What type of drug can be tested in crossover studies? D. So, generic drug, somebody say you include a brand drug, but because brand drug in a crossover study is not to be tested, it's to serve as a reference. Okay, and if a drug has cumulative effect, then it cannot carry to the next phase in crossover, the next stage. Okay, and so this so B. In a randomized clinical trial, double-blind means I have sent you a long email explaining the investigator and data analysis. I hope this is clear. I'm not gonna repeat this. 20. Okay. Which of the following is not true about phase 1 trial? The answer is sorry. Because phase 1 trial is healthy volunteer. Okay. I think in your group, I accidentally did not include this question. Okay. But this is about the NNT. This is about the NNT. Okay. I discussed this I'm gonna have to because I'm gonna update this assignment anyway. When I copy them, in 2 classes, for some reason this question did not copy through. Okay, so let me just make the update. Okay, so this is an NNT question.
We only had 20 questions.
Yeah, I know.
So there was 2 questions we didn't have, not just this
There are
one.
2 more questions. But it doesn't matter. Let me just I update this. Okay, because I copy. I don't know why.
Can I see number 21? The answer to this? So it's not true that you will want patients without comorbidities?
Okay, the key word here is patients. The phase 1 clinical trial is healthy volunteers. It's not patients with either comorbidity or no comorbidity. You understand what I mean? Understand? Okay. So that last question, randomized clinical trial, patients or myocardial infarction survivors. In the treatment group, 75% survived at the end of the trial, while 25 survived in the control group. Okay, while 25 survived in the control. What is the NNT in this case? Okay, in the treatment group, every 4 patients, how many deaths? the denominator must be one. In this case, it's 1 out of 2. Because you need to have a uniform outcome. In order to prevent one additional unwanted whatever events, in this case death, how many patients needs to be treated? Okay? With the treatment drug, compared to if they were treated with a control drug. Is that clear? Clear?
Are you gonna open the assignment for?
Huh?
Are you gonna open the assignment for review on campus?
Huh?
Are you going to open the assignment?
I said I'm gonna open this after this class, and it will be, the deadline will be next Wednesday.
So when you submit it, will you look back at it?
What do you mean?
Like, you know how on campus you can allow us to review the assignment after it's completed?
Oh, that one. Yes, I will allow you guys to review until the day of the midterm. You understand? Because I asked the earlier class, nobody wants to come here next Friday to do the assignment. Is that true? I mean, as you guys, it cannot force you guys to come. Okay? But I mean, so that means in the next assignment to the midterm, we're not gonna see each other. Okay? That means we need to keep contact, in emails or if necessary, in video, meeting or something, whatever, makes us the communication easier. Okay? So what I will do is we're gonna have the next assignment next Friday. Anybody wants to come here, next Friday? Chris,
Yeah, I'll be here.
are you gonna come here?
I mean, I think that everyone would prefer.
Don't answer it, just say no, okay? Okay, look, you wanna come here. Okay, yeah. So, we're gonna have to do
had
the assignment
a
and
percentage
the
to
midterm.
infection.
Probably not gonna see each
75%.
other in person. Okay, if anybody wanna come here, email me, I'd be very happy to come here, but I don't think anybody will come. And, so that's, so that means I will make this correct answers available to you guys until the day before the midterm. Okay, so stay tuned in reading all my emails, okay? If you don't wanna come, at the same time, you don't read my email, then please don't,
Like,
please, you are gonna have to be responsible for whatever,
it's doable for.
some optimal grades, which you may think.
I think that's why.
Understand? Okay, so for those of, just a few finished the assignment, I will need to erase your grade, okay? You're gonna have to do this again, okay? Two. All right. Okay. Any questions about the assignment? Yes?
What was 20 again? I didn't.
Ah,
Number 20.
20.
Yeah.
This one?
Is that 19 or that considered 20?
Double blinding means this one.
Yeah.
Is that clear?
Yes.
Do you mind if I come back in about 5 minutes?
How do you use time? It's okay. We're annoying. We get it.
Listen to you guys, listen to the video. I'm not gonna talk about this. Just, I want to talk about a lot about this. And this, I'll talk about this. Okay, so let's start with a little bit like, like this. Okay, so we start with the with the ecological study. Even though in the video I mentioned this, but let's just go a little bit through this, because I don't think that, it's the best to turn out to. So the ecological studies is still, the main framework is still a 2x2 table, the exposure and the outcome. But the numbers, the A, B, C, D, are not individual subjects who match the combination of the outcome and exposure status, but they are units. Either it's state, country, clinic, hospital, or any units that's reasonable in the data analysis. Okay. Therefore, the ecological studies almost can never be used to conclude any clinical of any clinical interest. You can almost never use just the ecological data alone to say whatever caused what health outcomes. Okay. But now let's give a specific example. Okay. Here. All right. So let's introduce the concept of KD over V. Anybody know what it is? Anybody worked as in a dialysis center? Okay. So KT over V is a measurement to measure the dialysis treatment adequacy. Okay. So what is the purpose of the dialysis treatment? Yes.
Filling the blood, basically.
Exactly, okay. For patients with a very significant kidney function damage, okay, because originally it's a kidney's job, okay, to clear the urine, okay. But the patients you have a significant kidney function damage, then they'll have problems doing that, okay. So the dialysis treatment is to help the patients with a kidney function damage in a very often end stage, RD, okay, to get rid of the urea, okay. So the K is dialysis clearance of the urea. It's measured as a ratio. It's measured as a ratio of volume divided by the time. The T is a treatment time per session, okay, per session. The V is a body volume, body fluid volume, okay. Based on my introduction about this clinical outcome, can anybody tell us what is the unit of KT over V? The unit, the blood pressure, the unit is mmHg, the height, like Luke say, is 5'10", 5'11", right? 6'5". I'm sorry. From the room? Okay, go. Luke is a great boy. And so he grew, okay, so just kidding. No, I would suspect that everybody in the class treat Luke as a brother, like younger brother, right?
Yeah.
Yeah, that's what I suspected, okay. And, okay, so now, okay, so in this case, what is the unit of the KT? Well, yes.
Is it milliliters over volume?
Huh?
Is it milliliters over volume?
The KT over V, not the KT.
Yeah, wouldn't the minute in the denominator of units for K cancel out the time?
So what is the unit of KT over V? It has no unit.
Yeah.
It's a proportion. Okay, it's a proportion. Okay, what does this essentially imply? Okay, let me just explain this to you. I believe you're gonna take some classes in the future. Okay, so K multiplied by T is a volume. Okay, it's basically the clearance, through of the urea expressed in volume in each section of the dialysis treatment. Okay, why do you think it's gonna have to be adjusted by a body fluid volume. Do you think for a tall guy, the same volume of clearance will be equivalent to a small girl? That's a big difference, okay? So it has to be weighed by the body volume, body fluid volume, okay? So that's a measurement of the adequacy of the dialysis treatment. Do you think low is more desirable or high is more desirable?
Low.
Low?
Hi.
High. Okay. It means, the dialysis treatment is effective. Okay, it's more effective. So somebody, you can establish it's very reasonable to establish a hypothesis, say, a high or acceptable, KT over V is associated with, more optimistic, prognosis, better, prognosis. The lower, the worse, okay? So in this case, if we use a clinic as the smallest unit of the study, okay, how many clinics are there in the category of the average acceptable KT over V? How many clinics? So there's 100 clinics in this case, in the entire study. How many clinics are in the category of an acceptable mean KT over V? A mean KT over V is all patients, take a sum and then divide it by how many patients. So how many clinics match the criteria of an acceptable mean KT over V for all patients in the clinic? How many patients? How many clinic? 60. 20 divided by 20 and 40. And the low is 40. Okay? So based on this, you will see 2/3 of the clinic with acceptable mean clinic KT over V will have lower overall mortality rate. While the same, is not for the clinic with a low average KT over V. Among clinic with an low, average KT over V is half. Okay? So based on this data, can you conclude for individual patients, the higher, the more acceptable the KT over V, the less likely he or she would die? I can tell you it is a very plausible, hypothesis, but you cannot conclude based on the ecological study, because there's no way for you to tease out potential confounding factors, because you do not have any individual level data. In order to tease out all the potential confounding factors, you will need to have individual level data. I remember last year, I think she asked me a question about ecological fallacy. I give a very specific examples, okay, and send it to the entire class and demonstrate if you do not have individual level data, there's no way for you to tease out the confounding factors. That is also the foundation for the ecological fallacy that we have talked about, okay? So based on this, what is the advantage of ecological study? The data is easier to collect than the individualized data. Agree? You just need to look at, a lot of sources you can collect. Accreditation criteria, accreditation files in the clinics, average KT over V, you can collect them. Okay, much easier compared to other study design that requires the individual level data. Okay, that's much easier. Okay, however, you cannot really conclude conclude any clinical, conclusion in this case that, an acceptable KT over V is gonna lead to lower mortality for, individual patients. Because you do not have individual data. You cannot, there's no way that you can, piece out the confounding factors. Even though biologically, clinically, it is plausible, but you need a further study to confirm that. In reality, it is very well confirmed, okay? Because a lot of studies in a cohort study, in a clinical trial, but, just for this data, you cannot. So this talks about, the vital statistics is one of the most common data source for ecological studies, and this is why the advantages of vital statistics, okay? Inexpensive, representative of all large groups and large geographic areas, available over long periods of time, and uniform coding rules. Vital statistics, and disadvantages, okay? The group ecologic data and no individual data, uncertainty, accuracy of the diagnosis, changes in the ICD codes, and variability in the coding practices, okay? A limited to available data, and mortality may not reflect, the incidence. And those are the just, limitations, and disadvantages. We have talked many times about, the ecological studies. I will not repeat this, okay? And this is another example of the ecological fallacy. It looks like that the countries with the higher smoking, gonna have a higher life expectancy. In reality, it's most likely, confounded by the GDP, because look at those poor countries, relatively country with, developing countries, many people cannot even afford the cigarettes, okay? And lower GDP is associated with, poor quality of care, okay? That's probably the reason, okay? But with this data, you cannot conclude, it's an ecological fallacy. And you have to collect individual level data in order to conclude your suspicion that it is confounded by the GDP. Okay. I think that's an example, and I'm just case reports. Okay, it makes the observations about medical phenomena in an individual patient, and simple description of clinical data without comparison group. Observations should be comprehensive and adequately detailed, okay? And the advantages of case reports and easy and inexpensive to do in hospital, and provides information on new diseases or new therapies, and useful in conveying clinical experience, and helpful in hypothesis formation, okay? And disadvantages and advice selection of subjects so that conclusions are difficult to generalize, where the findings or chance happening or characteristics of the disease is exposure really high than a comparison group, because there's no comparison group about the case report, okay? So here, I give a very specific example, okay? So now we all know COVID, okay, is gonna cause a lot of complications. Not everybody, of course, but it's gonna cause a lot of complications, okay, including cardiovascular conditions. Now we'll confirm that, right? But back in 2019, 2020, there's no systematic data, okay, to prove that. And this case report is about a lady with COVID, and she was 59 years old, okay? And her electrocardiogram analysis and cardiac ultrasound confirmed is ST segment elevation myocardial infarction. But this patient had no prior history of any heart condition. Okay, so and this highlights a possible association between respiratory infection and COVID infection and cardiovascular events. Okay, at that time, you can never conclude that association because you have no comparison group, you don't have enough sample size, you don't know what this is. But if you have a group of patients with COVID who had no prior history of a heart disease and they got a heart disease, then it's a very much stronger indication. Okay, so subsequently, this is a large scale data analysis to confirm the association. Okay, look at this. This is last published like about last year this time, the COVID heart 1 year after COVID infection, patients have an array of increased cardiovascular risk. Okay, this study is a much larger scale data and it can confirm, the clinical association between COVID infection and the cardiovascular disease. Okay, and but those studies, the foundation of those studies are built on numerous case reports and case series studies. Okay, is that clear? That clear? Okay. And deciding to publish, I think this is just a case series. Case series is a multiple, case report combined together. But the fundamental disadvantage is there's no comparison group. Okay. And difficult to address etiologic questions. So any etiologic investigation is about the causal inference. Because there's no comparison group, it is difficult to address the etiologic questions. Okay. And two case series so this is a case series analysis. Okay. And this is a case series analysis. Okay. First off, I hope this question is going to help you to strengthen your understanding about the incidence versus prevalence cases that we discussed in our last semester. We have talked about that in the case control study, the incident cases are almost always preferred over the prevalent cases. Guys agree? Okay. So why do you think when the outcome you studied is death, it really matters if it's an incident case or if it's a prevalent case? Do you understand what I mean? Do you understand what I mean? Doesn't really matter. If the patient needs to be just died, or died like a year ago and 2 years ago. Another case would be the patient just got a cancer, or got a cancer, a year ago and 2 years ago. What's the difference? Yes.
The account of time, incidence accounts, it's like per person years, whereas prevalence isn't. I might be absolutely honest.
Sorry, something else. It's okay. Okay. So what is the inherent problem about a prevalent case in a case control study? It is because after the patient has been diagnosed with a disease for a while, if you capture this patient that has diagnosed this disease 20 years ago and he's been diseased for 20 years, that's a typical case of the prevalent case, right? First off, if those who are very severe, they're unlikely to survive after 20 years. Okay. Second, over the past 20 years, after the diagnosis, the patient likely went through medical modification of their lifestyle, about everything. So if you ask them to record their past exposure prior to their disease diagnosis, chances are they are unable to provide reliable information. Do you think it matters in the case of death? If you die, then you die. Nothing is gonna happen to this person anymore. Do you understand what I mean? The death, is a totally different. I mean, after you die, they're not gonna investigate. Your afterlife, right? So, for the death, okay, the incident and the prevalent case doesn't really matter, okay, except that if you started 20 years ago, when you investigate that person's death and compare to a control who are alive nowadays, you need to control for the overall quality of health care. Okay, that's one exception. Okay, but otherwise, doesn't matter if this person has died a year ago or 2 years ago, as long as the quality of health care, the overall treatment, advancement have not been changed. Okay, so in this case, we looked at, this is a case series report, okay? Among 100 people who died after the 1 year of dialysis treatment, 70% of them had a low KT over B. 30% of them have acceptable KT over B. Can you conclude from this data that the low KT over B is a risk factor of a suboptimal outcome, such as death? Michael?
It's a suboptimal outcome, such as.
Can you conclude based on this case series study that patients with lower KT over B are more likely to die compared to patients with acceptable KT over B? Yes? You can unofficially say so. Because what's in your mind is that you have a picture of those patients who didn't die and their average level of KT over B. That's what's in your mind, right? Do you understand what I mean? But in order to officially conclude this, you need a control group, patients who are alive, and then compare their KT over B. Is that clear? Is that clear? Okay, so that's why the case series study is a bunch of case report. Okay, you still cannot, even if it's an individual level data, you still cannot draw any official clinical conclusion. But it's a strong hint in this case that a low KT over B is a risk factor of death. Okay. All right. So we talked about this KT over B. We're not gonna. Case series, advantage in informal patients and physicians about natural history and prognostic factors, easy and inexpensive to do in hospital settings, and helpful in hypothesis formation. Okay, and limitations. I think that's pretty clear. I think that does not need me to really. We just talked about. Okay, cross-sectional studies. It's at individual level data. That's a framework about the cross-sectional studies. It is an individual level data. Okay, and we looked at the disease and the exposure. For all the data collected at one time point. Okay, so in this case, okay, at the end of this year, you collect all the deaths and alive and their KT over B information when they're on treatment. Okay, based on this study, you can conclude that among patients who died at the end of the treatment year, okay, they are 1.4 times more likely to have low KT over B compared to patients who remain alive. Somebody may say, Dr. Gu, this is a very well-designed case control study. Why you are talking about this is a cross-sectional study? This is very true. reality, there's no solid with regard to the collection of the data collection point. You can define this as either a cross-sectional study or it's a case control study. Okay, because what you do is at the end of the year, you look at the clinical data to figure out the vital status of each patient. And then you collect their data in the same clinic based on the electronic health records to see their KT/OV value. Okay, you can say this is either a cross-sectional study or it's a case control study. Okay, but the indication of the study is that among patients who died at the end of the treatment year, they're 1.4 times more likely to have a low KT/OV compared to patients who remain alive. Is that clear? Is that clear? Clear? The last graph we're going to talk about today is this graph. Okay, can anybody tell us what if I have to tell you there are quite a few very important messages you can infer from this graph. This is a cross-sectional graph talking about the relationship between age and blood pressure, systolic and diastolic, by gender. What are the important messages you can conclude or infer from this table, from this graph? Yes?
About the relationship between blood pressure and age, so what people age, blood pressure.
Which blood pressure increases as people age? Which blood pressure increases as people age?
Systolic.
Systolic. What about diastolic?
Decreases.
It is slightly decreased. What is a clinical indication, or what is a clinical inference you can draw? Have you guys heard about a clinical diagnosis named isolated hypertension?
Yes.
So what is that, Chris?
Isn't it when, like, as you age, the diastolic blood pressure goes down because the walls of the heart are weaker, so, or you can have, like, leaking of the valves and stuff like that?
Exactly, okay? This indicates as you age, the more you age, the more likely you're gonna suffer from an isolated hypertension, okay? So an isolated hypertension clinical measurement is that the high systolic blood pressure, relatively low diastolic blood pressure, okay? What is the fundamental cause of the isolated hypertension? Artery stiffness. Artery stiffness. What is the pathophysiological cause? The number one pathophysiological cause of the artery stiffness? Yes,
Atherosclerosis?
exactly. As you age, the plaques gonna build up. Okay, the plaques, is gonna build up in your blood, the wall of your blood vessel. Okay, so is it more challenging to treat regular hypertension, or is it more challenging to treat an isolated hypertension?
Isolated.
Isolated, because all the antihypertensive meds, either those those decrease both of the blood pressures. Okay, the elderly are most likely to suffer, as illustrated in this cross-sectional graph. Okay, which is natural. Okay, because as they age, their artery stiffness, worsened when they age. Okay, and it's very challenging to treat this kind of, because it's inherent to aging. Anything inherent to aging, as a general rule, is more challenging to treat. because you cannot go against the mother nature. That's the philosophical reasons behind that. But I mean clinical reasons, you can't decrease both systolic blood pressure and diastolic blood pressure in this case. Okay, so it's very difficult, to treat. As a matter of fact, elderly people can easily suffer, they can feel, they can pass out because of this. And what is another important message you can tell from this graph? Yes, I'm gonna. Do you mind if I ask
No, I
another
don't
person?
care, yeah.
Thank you. Christy's, it's great. And let's ask another person. Let's ask a girl. Girl doesn't seem to talk a lot at all. Or ask a shy guy. What's a shy guy?
Oh, Anderson.
What was the question?
Yeah, this is about the worst answer I can expect. Okay. Yes.
You can tell that isolated blood pressure is more prevalent in non-Hispanic Black people.
You really give a great answer, and overall, okay, the racial disparity in blood pressure is more pronounced in women or in men.
And women.
Yes, in women, just by looking at at this graph, the racial disparity of the blood pressure is more pronounced in women, especially as they age. Okay, so I think that's pretty much what we talked today, and it's Friday, and I just want to let you know because the application of any of those cross-sectional tables can have many clinical implications that you can no way to discover by treating a specific individual patient. Okay.